Hello, dear ladies and gentlemen. First of all, I would like to thank the organizers for inviting me to this meeting. And I'm very happy to talk to you today on AML workup, especially with regard to subtyping, predicting diagnosis, and identifying treatment targets. My name is Lars Bullinger, and I'm a hematologist-oncologist by training, and I work at the Charité Universitätsmedizin in Berlin, Germany. And I regret that I was not able to come to your beautiful country in person, as I really would have loved to visit Buenos Aires one day, but hopefully there will be options in the future. But now I think we have to start with a talk, and I'm really happy to be able to talk to you today about the diagnostic workup of AML. Here are my disclosures. And the talk will have a brief introduction on acute myeloid leukemia. Then I will talk to you about new technologies on how we should follow up the disease, how we should measure residual disease, especially using novel technologies such as next generation sequencing. And then I will talk to you about novel diagnostic tools and big data approaches in AML before we summarize what we have learned today. I think you're all aware that to characterize acute myeloid leukemia according to the World Health Organization classification from 2016, which is currently being updated, we need information on the genomic aberrations of leukemia. On one hand, of course, also the previous medical history of patients is important, especially as patients that have been treated for some other cancers and then later develop acute myeloid leukemia are classified as therapy-related AML. But importantly, we have to look at the cytogenetic and molecular genetic aberrations that lead to the transformation of the hematopoietic stem cells. And if we identify one of these recurrent genomic aberrations, we will term the leukemia AML with recurrent cytogenetic or genetic abnormalities. Then also, especially important in our older patients, very often AML is related to a previous myelodysplastic syndrome, and we term these leukemias as AML with myelodysplasia-related changes. And here it's also important that we look at the cytogenetic abnormalities the leukemic blasts have acquired, as for example, AML with complex karyotype is considered AML MRC, and MRC AML now can be treated differently as new drugs have been approved for that AML subtype. And only if we do not find cytogenetic aberrations that help us to further classify the leukemia, we still rely on the morphological criteria, and then the AML will be termed not otherwise specified. But I think many of you are aware of that, and also of the fact that these cytogenetic abnormalities do not only contribute to the improved classification of the leukemias, but also to an improved risk stratification. And here we usually use the guidelines that were prepared by the European Leukemia Net consortium. And within this ELN guidelines, risk categories were defined. Favorable AML, you all know, is associated with core binding factor leukemia aberrations involving the RUNX1 gene or the CBF beta gene, or NPM1 mutant leukemias without the presence of FLT3 internal tandem duplications, or if they are present at a low ratio, and CBP alpha mutant leukemias. In those cases, we usually do not move forward to allogeneic transplantation with our patients. But if we find these adverse risk factors, such as complex karyotype or the recently added genomic aberrations involving the RUNX1, ASXL1, or TP53 gene, we know that the leukemias will progress rapidly, even if we get them in complete remission. And there is a definitely high need to move forward with allogeneic transplant in these patients. But then the picture is even more complex. While the cytogenetic and genetic aberrations that define the leukemia risk groups that are color-coded here in the middle already reflect the quite heterogeneous picture of AML over the last years. From sequencing studies, we have learned that there is many additional aberrations that subclassify the leukemia cohorts, especially if you think of the NPM1 mutant leukemias. We have heard that FLT3 impacts the outcome, but other mutations such as PTPN11, for example, do as well. And here we really have to learn more in the future to identify these gene-gene interactions that help us to better predict outcome in our patients. But on the other hand, those markers are also helpful with regard to better follow up the patients and to use these markers as, for example, markers for measuring measurable residual disease. With this slide, I want to show you that those markers are relevant and that they are not only relevant with regard to their presence, but that they are also linked to the age. You're all aware that younger patients do better. Very often it was thought that this is the case because we can treat them more aggressively, we can more rapidly move forward to allogeneic transplantation. But here what I want to show you, on the y-axis we have plotted the age of the patients, and on the x-axis you see the different mutations, and on the x-axis, the z-axis, the frequency of the respective mutations. This is a meta-analysis of over 10,000 AML cases from our German and Austrian AML study group. And what I want to show here is that the problem with the older patients is that the biology of the disease is changing, that especially in older patients, we have these high-risk genetic abnormalities, P53, ASXL1, and RUNX1. And this is one of the additional reasons why we are doing so poorly in treating these patients, why they very often do not respond to chemotherapy. And here we really need new treatment options. For example, venetoclax, a BCL2 inhibitor that was recently approved, can help here, but also other new treatment approaches that have, if you think of immuno-oncological treatments. But on the other hand, it's also important to closely monitor the disease, to look for these markers in the future, because they will help us to better guide our treatment decisions. And this is also now reflected in the current treatment guidelines. Here is an example, the recently revised guidelines by the European Society of Medical Oncology from last year. You see that we do not treat all leukemias the same anymore. If you have a favorable risk core binding factor AML, for example, you will get classical chemotherapy 7+3 in combination with gemtuzumab ozogamicin, an antibody targeting CD33. Combination improves outcome. In contrast, if you have one of these high-risk markers, you have therapy-related AML or AML with myelodysplasia-related changes, such as AML with complex karyotype, and you are still young and fit. That would be, for us, for example, a patient in the early 60s. Now we have the option to treat these patients with the new formulation of 7+3 in a liposomal construct, CPX351, which leads to much better response to therapy in these high-risk patients. And then we now also have targeted therapies available, tyrosine kinase inhibitors, which we can use in FLT3 mutant leukemias, or new chemotherapeutic drugs that can be explored. But then the new guidelines have also changed with regard to monitoring of the disease. Measurable residual disease, or minimal residual disease, how it was called in the old days, is now getting more and more important, especially as we have new therapeutic options with regard to maintenance therapy. If you think of midostaurin or the recently approved oral azacitidine, if we have patients on maintenance therapy, we should monitor them, because if they were MRD negative and turn MRD positive again, this might indicate relapse, and one might think of allogeneic transplant concepts in these cases. So measuring residual disease is becoming more and more important. But as there is more and more markers out there which we should follow up, we need new strategies, and we should use also novel technologies to do so. And here, next generation sequencing offers one of the opportunities. So with regard to MRD monitoring, with regard to its clinical relevance, when should we do it? Of course, it's important, as I had pointed out to you, that we look at the molecular and cytogenetic aberrations at the time of diagnosis. This is not only important with regard to the classification of the disease, but also with regard to risk stratification and our therapeutic decisions. But then we should follow up on the MRD levels, because we know patients that respond well, that turn MRD negative quickly, they have a much better prognosis. For some of them, we do not even need transplant. We know that pre-transplant MRD level is one of the most important risk markers. And then also once our patients are transplanted, we definitely also should follow up the MRD levels, as after transplantation, we have several options to impact the course of the disease. As for example, if a patient still is MRD positive or gets MRD positive again, we, for example, can take preemptive therapeutic measures, such as, for example, altering the immunosuppressive medication, or by, for example, starting a maintenance therapy with kinase inhibitors. So we have several options in that setting. And here I want to also share some of our recent data on NPM1 mutant patients, where we had followed them by measurable residual disease in our AML-SG 0909 trial, where patients received intensive chemotherapy in combination with gemtuzumab. And here you can see that the patients that were MRD negative, the blue line, the risk of incidence, the cumulative incidence of relapse, the risk of relapse is much lower than when the patients remain MRD positive. So it is important to follow up on our patients, because if they stay positive, we really also should think about, for example, allogeneic transplant concepts in these low-risk patient cohorts. So what is the current state of the art with regard to measurable residual disease testing? Of course, you can use multiparametric flow cytometry to look for the leukemia-associated immunophenotypes. This is a very good approach, as it can be done in all our patients. The problem is that it's not so sensitive and that it needs a lot of expertise. So more objective are classical molecular biological approaches using quantitative PCR, digital droplet PCR. Problem here is that you only can look at few markers at a time. So we now really want to investigate further approaches where we use next generation sequencing, as this allows us to really capture the full heterogeneity of the disease and to follow up on all the markers at one time in the patients over time. And then just for completeness, of course, for the allogeneic transplant patients, you also can look at the chimerism of the disease, which is also a good approach. With regard to next generation sequencing based measurable residual disease technology, here we use also panels. Ideally, we would like to use the identical panels we use at the time of diagnosis to define the molecular aberrations, and then use the identical panel to follow the patient over time. And this is work which we have done together with the colleagues in Hanover, Michael Heuser's group and Felicitas Thol's group, where we use a PCR-based protocol with molecular ID barcodes that allows us to increase the sensitivity. And here is an example shown for IDH1 mutations. So we can follow up these mutations at a high sensitivity and specificity over time. In addition to that, we also have developed assays that allow us to use next generation sequencing to monitor the internal tandem duplications of the FLT3 gene. You're all aware that with next generation sequencing, usually can do very well with regard to the detection of point mutations, but these shotgun sequencing technologies have problems in detecting larger insertions and deletions. Here we have combined then a PCR-based protocol with a next-generation sequencing-based protocol to follow up the cases over time. And why is this important? Here I want to share some data which was recently published from our group in Blood, where we have looked at leukemias that were treated with midostaurin over time. And we saw that several of the cases developed relapse or refractory disease during the midostaurin maintenance therapy, as you put the leukemic cells under selection pressure, and this can result in different resistance mechanisms. Some patients, you get downstream mutations, so you still effectively block the FLT3 ITD, it's still present, but you have the same pathway activated below. But others lose the internal tandem duplication. That means that midostaurin is still effectively blocking that clone, but a different clone then gained a growth advantage. And by better understanding this in the future, we hope that we can better modulate our maintenance therapeutic approaches, for example, by switching the kinase inhibitor at an early time. And so I'd mentioned to monitor that now also very effectively at high sensitivity and specificity. We have developed a PCR and next generation sequencing combined approach with which we really can detect these internal tandem duplications and do this at a high sensitivity and accuracy. And with this, we can monitor the patients over time. We can see that the clones disappear, they reappear at relapse. Some of the clones are then the ones that are driving the relapse. And by better understanding these mechanisms, we now have looked at many leukemias. We could show that MRD at the end of treatment is one of the most important markers that predicts for the cumulative incidence of relapse. And if we look at more of these patients in the future, we hope that we also can use that therapeutic approach to that diagnostic approach to modify our therapeutic approaches. And in the last part of my talk, I briefly want to share some new diagnostic tools with you and big data approaches, which I think will lead us further to better manage leukemia in the future. So one hand, of course, I think to characterize the disease at the beginning, we should use gene panels to identify all the markers that are relevant. So the question is, what is an optimal panel? It definitely should include the markers that are relevant in the European Leukemia Net guidelines, and also markers which you might treat with novel targeted treatment approaches such as IDH1 and IDH2 mutant leukemias, where we have small molecule inhibitors that recently were approved by the FDA. But in addition, we also want to look at markers that can be used to assess measurable residual disease, or where we know that they might have poor prognostic impact, such as PTPN11, for example, or RAD21, which has good prognostic impact in NPM1 mutant leukemia. So currently in our lab, we do a gene panel that comprises 42 genes that are of relevance with regard to the current classification and risk stratification guidelines. Those are the ones labeled in red again, and the others which we think are important with regard to disease biology and measurable residual disease. But then recently there was a publication coming out or published by Timothy Lay's group that suggested in the future we should move forward with whole genome sequencing. They provided a pipeline with Illumina-based sequencing that is very optimistic. So far, only few labs in the world can do that. This will also involve high costs. But on the other hand, I also think this is the way which we will go. And I think in a couple of years, the sequencing costs will be definitely cheaper, that we can do this. And in that way, we really will get a comprehensive picture of all of our patients. We in our lab, we also try to do this, but we use a different technology. We use Oxford Nanopore sequencing technology, and that also might be interesting for many of you, because this is a new technology where you do not do really sequencing by synthesis anymore, but where you use biomembranes with protein pores. Over the biomembrane that is shown here, there is an ion current, and the DNA basically only flips through the pore. And when it flips through the pore, the nucleotide that is currently in the pore, in the middle of the pore, changes the ion flow over the pore. And that change in ion flow can be directly translated into the individual base that is flipping through the pore. In that way, you generate DNA sequencing data in real time, and in that way you can really move forward. In that way, you really can generate DNA data in real time and sequence an entire genome more or less overnight. I now try to start the presentation, but for this I have to, now I can start the video, which you hopefully will see. So this is how it's done. So you only have to add a molecule that allows the DNA to flip through the pore. So the library generation is quite quick. When the nucleotide flips through the pore, it changes the ion current through the pore that is directly translated into the nucleotide sequence. This is a very fast process. The advantage here is also that you can sequence very long DNA strands. You can go up to 100 kilobases. In that way, you also can get very good information on the genomic aberrations. In our lab, we have set up a DNA-based approach. You can do the same for RNA. That allows you then, for example, to detect fusion genes at high sensitivity and relativity. And if you run the two protocols in parallel, you can get very accurate genomic diagnostics in labs. So this is an inter-lab test where we have run the same cases in two different labs in Germany. Again, this is a collaboration with Hanover, with Michael Heuser's group. You see, it's more or less a foolproof technology. You get very reliable results, and even complex genomic aberrations, such as this case with chromothripsis, which is a shattering of chromosomes, you can easily detect the complex karyotypic changes, and in that way, you have the diagnosis of these genomic aberrations within 48 hours, and you can then start treatment in these patients, for example, using new compounds such as CPX351. And in the future, we think that those technologies will be even further refined, that we will be also able to look at the genomic aberrations not only in the bulk of the tumor cells, but also to identify them at the individual cell level. And I think these single cell-based approaches will help us to better capture the heterogeneity of the disease within a single patient, and to identify whether at the time of diagnosis we have these high-risk subclones that can lead to disease relapse. And in the future, hopefully with more therapeutic agents becoming available, we can also then address these subclones and prevent that they will be responsible for relapse. And to do this, to capture the heterogeneity of the disease, I think we really all have to work together. And in Europe, we have now started this Big Data for Better Outcomes initiative, a Harmony project it is called. It's a huge multi-stakeholder initiative where not only academic partners, but also pharmaceutical industry, regulators, patient advocates, payers, health technology assessment bodies are involved. And we all work together to really capture the molecular heterogeneity of hematologic diseases. For AML, we already have put together over 5,000 cases in the database. There is over additional 5,000 to come in, and I think with 7,000 cases collected, we really can capture the disease heterogeneity and the impact of these gene-gene interactions on outcome. And this will help us to better risk stratify our patients and to identify the markers, for example, which also have to be used for measurable residual disease monitoring. And with this, I'm now at the end. I think I went a little over time. Just to summarize again, those are the German guidelines from 2021 to show you again, molecular aberrations are playing a big role. We have risk-adapted treatment options. The MRD level is becoming more and more important, as it will have an impact on how we consolidate the patients, for example, and how we follow them up. And there is also light at the end of the tunnel, not only with regard to the improved diagnostic approaches, but also with regard to new therapeutic options. This is a nice review that was recently published by Hartmut Döhner, Andrew Y, and Bob Löwenberg, my mentors more or less, that shows you that we do not only have more targeted therapeutic approaches at hand in the future, but there's also more immunotherapeutic options becoming available, such as, for example, the CD47 antibodies, magrolimab, that might give us additional tools, especially to address the MRD positive states, and especially to help us in patients that are not fit, for example, for allogeneic transplantation. So I think we are entering very exciting times. Better understanding of the disease is helping us already today to better manage our patients. If we continue to better understand the disease in the future and we have these new drugs at hand, I think we even will do better. The only thing is then, of course, we will have to think about ideas to better battle financial toxicity, as many of these new treatment approaches are expensive. But I hope that in the future that also might change, that not only the diagnostic approaches become more affordable to everybody, but also the treatments. And with this, I'm at the end. I hope that I could give you a comprehensive overview on the topic, and I hope you will have a very good meeting. Thank you very much for your attention.